el tamaño, the size is too heavy because I have pictures.
Okay.
How should we do that? Sorry, I didn't know.
Do you have a link for your presentation?
No.
The original one? No.
No,
So if you have it in your browser, you can open and export again. Try to if you did it in PowerPoint or Canva, I don't know which one.
I did it in PowerPoint.
So you can go there or maybe save as, and whenever you're saving, he is gonna ask like how heavy. If you wanna compress or something, or an option like that, maybe save as.
So I could I send it to one of you as we transfer? I think that I'm sorry about that. So I think that may be the easiest. I don't know how to compress. I don't think I have anything to
Try sending to me, Isabelle.
Okay.
I'm gonna
Sorry
try
about
it.
that.
Okay, let's start. We are already on YouTube. So good afternoon, everyone. Welcome to the International Seminars on Health, a course offered by the Postgraduate Program in Nutrition at the Federal University of Santa Catarina, Universidade Federal de Santa Catarina, UFSC. I am Ana Carolina Fernandes, one of the professors of this course, together with my colleague Deborah Higer and our postdoctoral fellow Mariana Kremer, who are here too. We are delighted to have you with us today. Some students of the course here in the StreamYard platform and others via our YouTube live stream. Today, we will have two speakers. Our student Ana Milanese will be hosting Dr. Isabelle Michaud-Letourneau from the Université de Montréal in Canada. And our student Catiel Schmidt will be hosting Dr. Thais Favero Alves from the University of Nebraska Medical Center, USA. Well, for each seminar, we will have a presentation by the guest speaker lasting between 15 to 30 minutes, followed by a 15-minute question and answer session, where you will have the opportunity to engage in discussion, to ask questions, and so on. Now I would like to invite Anna to introduce our first guest. Isabelle is facing some problems to present her PPT, but we are trying to fixing it. Maybe Anna can start introducing Isabelle.
Okay, good afternoon, everyone. I am Ana Milanese, and I am a postgraduate student at the Federal University of Santa Catarina, Brazil. And I'm very happy to introduce you to Dr. Isabelle Michaud-Letourneau. I'm going to say this only once. She has worked in clinical, community, public, and international nutrition since 2003, when she completed her bachelor degree in nutrition at University of Laval, Quebec, Canada. She holds a master's degree in public health from University of North Carolina, USA, and a PhD in international nutrition from Cornell University, USA too, and a postdoctorate on interprofessional collaboration from the Université de Sherbrooke, I think, Canada. Globally, Isabelle has completed projects in maternal and child health with approximately 20 countries in the Americas, Africa, and Asia. In 2018 and 23, she worked for Society of Implementation Science in nutrition, applying implementation science to improve iron and folic acid supplementations programs in Kenya and Uganda. In Quebec, Isabelle is an adjunct professor in the Department of Social Preventive Medicine at the School of Public Health of the University of Montreal. She also teaches a core course on interprofessional collaboration as a lecturer in the TESS, which is called Advanced Interdisciplinary Approach to Breastfeeding, my special interest, at the Université du Québec. In 2019 to 21, she was a nutritionist advisor at the Ministry of Health and Social Service and served as president of the Baby Friendly Initiatives Certifications Committee. And she's a member of IBFAN, advocating for the code, very important code. Today, she's gonna share a bit of her experience on this important field of perinatal nutrition. Thank you for being here with us today. I now invite you, Isabelle, to begin your presentation. Did you manage to send me so I can share the screen?
I did manage,
Yes.
and so you'll receive, and then I'll just maybe share a few words while you're trying to do a project. I apologize for this logistical problem with the internet. So thank you very much for having me. That's always a pleasure for me to speak with graduate students, health professionals, people who are interested about public health, international nutrition, because it has been a passion for many, many years. And so today I was asked to share a little bit about my background. So I put a few slides together and hoping that it will trigger some questions afterwards that we can have a discussion. I'm a nutritionist by background, so I've been engaged in nutrition project all my life, but always with different glimpse in terms of sometimes it was clinical nutrition at the beginning, working in hospitals, but then I realized I didn't want to be in a hospital forever because I felt it's more curative and I wanted to have more preventive, which led me to public health and then working with community nutrition for a few years. And I realized that working with communities, sometimes communities are affected by more policy. I didn't know at that time it was like more the policy that governments are doing and writing, but it has a lot of influence. And so every time that I continue on my academic path, it was always just to get to know a little bit more and be able to have more tools. And so I will share with you at the end a few advice, but one advice that I always give to people who want to maybe have a similar path or are starting their graduate path or professional life is just like take as many tools as you can, because every project bring you a lot of value in terms of opening our visions. And so this is I feel that I have been fortunate over the last couple of years or last many years. Now I've been a nutritionist for more than 20 years because when we work in international nutrition, we need to understand really many different project problems, solutions. And so I feel like whatever you want to do, go in what the life brings you. And even if it's not always easy, it always brings you a lot of value in terms of being able to address problems later on. And sometimes, I will repeat at the end, but sometimes when you feel that it's more like a failure, you have more learning. So that's the good thing of it. So when you see project or problems as always a learning opportunity, then it alleviates your shoulder because there is no failure. There is just learnings. And then you try to get the most from the experience and what lives bring us. So I'm going to ask to Anna if now it's seems to be working. I'm a visual person, so I always like to put a lot of pictures, but it's heavy to send. So Anna, how is it working?
Yeah, it's loading. I think in a few bits we're going to have it.
And so what else? Maybe I wanted to share a little bit in terms of an opportunity that I had that really transformed my life. And I'm going to talk to start, but it's, I received a scholarship, fellowship of 2 years from Rotary International, which was I was a Rotary World Peace Fellow. I will talk about it in a presentation, but if you like to travel, have different language skills, think that you would like to get more skills in terms of conflict management, and sometimes I say this more broaden, it can be a good opportunity for you. So I will talk in a minute about it. So You probably can see all of this. Who am I? You can now present the next. So I always say that I feel myself as an international nutritionist engaged with many stakeholders. I had the chance to be engaged with different people working in their country. And this has been a very valuable, because my research and my practice has been to try to understand how those different people try to make change in their country, try to improve public health, nutrition. So I call them change agents. And so over the years, I got the lens of practice, but also research of seeing how are they able to change the needle in their country. How do they become change agents? And you will see this is like a stream that has been really emerging from all the things I've done. Is I feel like we can really make changes, even if we are one person. And so I'm a dreamer, and I've seen many people who were able to have different triggers in their countries and move, being on the code, on the baby friendly, on breastfeeding. So I know it's many of you are interested about that. So we are stronger when we are many people. You can, so sometimes people ask me, well, can you have a family while doing those different things? And so I say yes. And so I present my family. I have 4 children. I don't say it's easy. It has been challenging sometimes, but it's my double life. I think my children help me to keep balance, which is important. Sometimes I'm a mom that goes the other side of the country or the world for a few weeks or a few days. Now it's less and less, because I try to be more present. And we had a fun project, which is to change, buy a school bus and change it into a little vehicle so we can travel together. So this is being to answer the questions. Yes, we can work in international nutrition and have an academic life while working in other countries. It's just it requires a little bit more planifications, organizational skills, but it's possible. So you can go on the next one. I consider myself a global citizen. I'm very much affected right now, but everything that is happening, I feel like we are just one humanity, and it's so important. And so I had the chance to work with many countries, and I always encourage people to travel and to get to know others, because it's important when we want to consider a problem or a situation from their perspective. So those are the countries that I was fortunate to work with. I don't know them to the same extent. I know more Mozambique, and so I'm going to talk a little bit of the work that I've been doing, because I did my doctoral project in Mozambique. You can go to the next one. And so you present myself with educational background. So I will quickly say, so nutrition is really the main focus of my work as a nutritionist. Then I continue doing graduate studies, because as I mentioned, I wanted to learn more, but I never thought I was going to do a PhD, and especially not a postdoctoral fellowship afterwards. But life brought me that. I don't consider myself as a pure researcher. I feel like my research is always to try to improve practice. And my research is just to try to learn from practice. And so I feel over the last couple of years in research, there has been more acknowledgement of all the tacit knowledge that practitioners have. Sometimes we say that there is a big gap in terms of when we know something from the research and the application of it. Before, it was a gap of 10 years. You can imagine 10 years, it's a long time span in terms of being able to apply what we learned from research to practice. And so I've spent more times in the last couple of years working on implementation science, which may be a term that you've used, but it's really a big area in health that has really gained much attention. And I work with the society to try to develop implementation science in nutrition to try to shorten this gap, because the gap now is about 17 years. And so I feel like one of my task or goal is to try to making sure that what is in the literature out there, we try to digest and try to apply it. And so I saw myself oftentimes as playing a role as knowledge broker. So I'm just throwing terms that it may raise some questions afterwards, but definitely. A chance that I had that I was mentioning was I did graduate studies in peace and conflict resolution studies, and so open your ears if you are at the level that you would like to do a master or another master. Sometimes it's for mid-career professionals, and Rotary International is a great organization that people really want to do good in life, and those clubs have developed in all countries, and so they are an amazing network of people. And what they've done is they have put an endowment and they have created a program that allow at that time it was 40 students per year in the world to do studies in peace and conflict and resolution studies. And so I was fortunate to be able to do that. If you Google it, you can find every year they give those scholarship. You need to go through a club. It's a long process, but it's worth it. If you have some trends or experience in global health and you want to continue with this, I often say is that in all the works that I've done, because I will just give you some ideas of my experiences, I always needed to have a solid background on nutrition. But what helped me to survive was really all the skills in conflict management that I got, because oftentimes we don't call this a conflict, but when you have many organizations working together, you have peoples with their experiences, with their values, and then it's hard to have them work because sometimes there is no consensus, or sometimes there is personality issues. So by being able to play this, those social skills are extremely important, and especially when we work with across different settings for the different countries, then you have even more the culture that comes into play, and misunderstanding that can really become dire if they're not addressed. So I feel like many times I call myself like an architect of process, because oftentimes I need to say, okay, we have a problem. Now, how can we try to move forward, being just developing relationship, clarifying misunderstanding, or being able to manage a long-term goal. So next time, I'm talking too much because I'm trying just to give you some ideas, because I know it was what was asked in terms of my identity as a professional person, but also I know many of you may be considering working in international health. I was fortunate to be able to study at Cornell University. So I was accepted to do the PhD program in international nutrition. But to be honest, I'm a passionate person. And sometimes when I'm passionate about something, I go and then I realize what the implication. And so I didn't think I was going to well, I spent 6 years doing the PhD, so I think I didn't realize how long it was going to be. At least I had 2 children at that time. But if you're thinking about maybe a PhD, sometimes doing a PhD launch you to a certain path, oftentimes that is in academia. And nowadays, it's more and more difficult to get position in academia. So sometimes, like the master, if you're a practical person, maybe enough in the sense that you will get to work on many projects. Sometimes doing a master, also after you work on project, that is almost doing a PhD afterwards, but you are not in a strict program. You can always continue learning. So I think the PhD path is something to consider well, and I don't think I had considered enough, but I don't regret whatsoever, because I had the chance to have an advisor who was very practical and who found me because of my background in peace and conflict resolution. But I would say an advice, if you're going to take the PhD path or you're thinking, is really try to find a person that you get along well, because you will work a lot together, and that you see yourself as really building something with this person. So one lesson in the time. So you can change. I mentioned about the Rotary World Peace Fellowship. During this fellowship, I had the chance to, you can go afterwards. I had the chance to work with the Makua population. On the next slide, you will see this population. They are in northern Mozambique. And so we were a group of people who were selected from different countries. So the program is amazing. At the same time, being able to learn from like the 15 different nationalities that are in your group is also another amazing opportunity. So I think it gives you really an opening in terms of other people's mind, other values. And so this was just to introduce myself, but I already did, but I am someone who really liked challenges. So here you saw the mountains. This was my group at that time. It's a group that I learned a lot from. And there was one class, and I've talked to you a little bit about my academic path. So I've studied many years. There is one course that changed completely my life, and it was called the International Conflict Management. And sometimes people were asked, like, what a nutritionist does there? Because you think, well, international conflict management, you're talking about countries. But when you're talking about countries, you're talking about people, and the head of those countries are people. And we see now with all the conflicts that are in the world, like the personality of the person, the way they handle global issues, the administrative work, and the policy that they're doing is really influencing. So after all, we are all human beings. And so even at the scale of a country, you need those skills. But even in our daily life, as I mentioned, you can go ahead. So every year every semester we had one class that was on international conflict or different things. And this person, Professor Terry Barnett, who unfortunately passed away, but was an amazing person. So every Friday we were negotiating. And so we had a role to play, and then we would interact and try to gain, and we would use different tools. And this is something that really changed my life, because every time I would say, Terry, like what we learn in your course is so valuable. Like, we need this in public health. And one day he challenged me and he said, well, write your own role-playing exercise and do it yourself. And since then, I've been doing this in my courses. And to be honest, I feel like I don't want to stop, because my students, when they have this role-playing exercise, it gives them like one concrete event together that they try to negotiate, and it doesn't work, but then it opens up to just try to learn together. So I try to have a safe space, and every time they say, well, if you change anything to your course, that's okay, but this kind of class and role-playing exercise, don't ever change it. And so this is why it encouraged me to continue, because sometimes we have a lot of knowledge, but trying just to get more skills in terms of how do you do that. Next slide. Thank you, Anna. So, well, this was my my people. So those were the people that I interact more, just to put some face into the experience. But next one, in terms of the conflict management, so what do we do? So I just give you a glimpse. We try to break a conflict into small parts and try to address them, because sometimes it seems to be so big. So when you put different lens, it helps you to say, okay, I'm going to take this piece and what could we do to address this problem? So you have two people that don't get along. How can we try to fix this? It will help the group, for example. You try to put yourselves in other people's shoes and see the world from their perspective. That is not always easy, but that is very important. You use different tools for different conflict or problems. Next slide. And so this is just to give you that there are an idea that there are a lot of tools that can be used for that. In terms of the master project, so it was the wonderful Makua population that work and live in rural Mozambique. As a nutritionist, I wanted to continue in this area, and so at that time, there were 43% of the children under 5 that had chronic malnutrition. And so I work with an amazing team of people at the national level, but also at the district level who were working with agriculture, with also the health staff, with Save the Children. So I spent a couple of years working with Mozambique. Next slide. Then Save the Children, that may be an organization that you know, but that they were working on the food program for that time. It gives you just an idea. My 2 colleagues down there who were amazing person, who work with those community volunteers. And so as a nutritionist who work in global health, public health as well, sometimes I needed to do like something that were very technical. So I had the chance to review national guidelines for acute malnutrition. But to be honest, sometimes it was not just the clinical things that was the challenge, is to working with everyone and try to get agreement. So again, an example, develop a social and behavior change communication strategy. So you think that you go in a place and you develop this with the team, but then you realize that the team has some challenges in working together because they don't understand what the others are doing. So you need to do some team building. So again, it emphasized, my advice to you is take as many as you can in terms of project, because you will get skills. And the skills that were very helpful to me is in terms of evaluation. So how do you build an evaluation right at the beginning of a program? So sometimes you can just take courses on the side, but that can really help you strengthen how you do intervention in the field. Next slide. For my PhD, I was already there, and I wanted to study coordination on the multi-sectoral action plan for the reduction of chronic malnutrition. And because I was there, and the person at the Ministry of Health was really overload completely, so they decided to hire me to support her. So for almost 2 years, I studied at the same time as I was doing. So again, as I was mentioning, is, well, with a master, I had enough skills to be able to supporting her. I was on top of that studying this process, which was very valuable. But it depends. You just need to ask yourself the questions, or what you want to do afterwards. Is it more the research part? But sometimes you just also take the opportunity that comes. So I feel like this is what I've taken. I wasn't opportunistic, but in a good sense, in the sense that I had the chance of being interacted. So how am I going on time? Because we start a little late. So I only have a few more slides, but I just want to check with you.
Girls, can you help me with the time?
Because there is someone else, I just want to make sure that
we have until 3 p.m. We have another 30 minutes to questions and answers. And
okay.
So, but you can keep talking, and we can do the questions later.
Okay. Good. Thank you very much. Yeah, we don't have the time, so that I appreciate the half an hour. Okay. So next slide, Anna, please. So PhD project I just mentioned, but one thing, so maybe one lesson that I want to hear, sometimes to bring attention to breastfeeding, especially right now, because I'm trying to work on this issue, but on public health, sometimes having a big event help you to build a collective project. And I think this is an important lesson that I've learned that I'm trying to recreate over and over, and it works. So at that time, we received a good funding from the USAID, but mostly from Danida, the government of Denmark, to do a 3-day seminar workshop in terms of we were inviting people from all the country to be able to present. So they were presenting their work. So we were really planning well in terms of everyone had a role to play. In green, you have all the students in nutrition that we train and support the work that we were doing. So they were very helpful. On the left side, you have a picture of many people, many participants, but on the front row, you have the ambassadors. So at the end, we were able to have the ambassador from the countries, the main donor countries, to present them some of the work. And the Prime Minister of Mozambique was there to do the closing remark. So and we had done a video also with the First Lady that was there. So by having a big event, sometimes it gets political attention or attention from different stakeholders. And it helped us because when you have the Prime Minister doing the closing remark, you're the one writing. So we were the one writing the speech. And so we had to go back and forth with the advisor. But at the same time, it do a lot of awareness. And so by really using those opportunities as working together, developing trust together, trying to align our efforts, this is something that I've done tremendously and that has worked. And so it's sometimes difficult to get the buy-in from the government. Sometimes they are not ready. In some countries, it's easier because you have the donors that have a lot of power because they are much present. So back home, it's a little bit more difficult sometimes, but it's really, it helps us just to express ourselves, and people can really share what they're doing, because sometimes you realize those two organizations are working on the same issue. They're not talking to each other. So oftentimes I would say, like, don't be afraid to go talking to others just to understand what they're doing, because there may be some good collaborative opportunities that we are not obligated to do by our organization. But really, when we think that we work in a big systems, it's powerful to work together. Next slide. So quickly, I just mentioned the postdoctoral. As I mentioned, I didn't think I was going to do one. I had an opportunity to do one. So I worked how to improve the collaboration of nurses and medical doctors. But just working on collaboration has been very helpful. And I did an assessment I want to quickly discuss on the next slide. So I was doing my postdoc, and there was an opportunity to work on advocacy. Quickly, you may have heard about Alive and Thrive, or maybe not, but it's an organization that works a lot on infant and young child feeding, or maternal, maternal and child health. In fact, it's broader than that. And the Southeast Asia, or more the Pacific now, team has worked tremendously with UNICEF to do some work of advocacy, to try to have the International Code of Marketing of Breast Milk Substitute to become the legislation in many countries. Because some of you may know, I think, and I've heard about breastfeeding, so many of you may know about the International Code. But this International Code that was developed by UNICEF and WHO in 1981 is very important, has been really actualized over the years. But it's not applied in countries as long as the country don't decide to put in its own legislation, and it doesn't happen by itself. So I follow over the couple of years now, I've been following 14 countries now, I think, to see how do they do advocacy to make sure that some provisions of the International Code are inserted into the legislation of the country. And so Alive and Thrive has worked tremendously, has done a lot of good things with UNICEF and the partners countries. So the governments are always involved. So this is important work. And what I realize is with those skills is advocacy is something that we don't learn enough in nutrition or in public health. But if we want our items or our issue, our problems that is close to our heart to become on the agenda, we need to develop those skills. So how do we build evidence to try to advocate? And so you have a supplement, I put it there, of the papers we have written on this. But how do you advocate or do you have people coming around and you have the evidence also to show what will convince them? So I think those are important skill sets to develop. Next one, I think I'm getting to the end. Oh, I did volunteer work in Quebec. So my volunteer work in the last 12 years, I've really fed into my professional work. So I work for the Quebec breastfeeding movement. I was on the board of directors, training committee. We try really to enhance the breastfeeding education of health professionals in many countries. That's a challenge. I don't work on promotion. I feel like breastfeeding promotion, it's important. But if we don't work on the support of health professionals, if we don't have an environment that's more enabling for breastfeeding, the more we do on breastfeeding promotion, the more pressure we put on women. So I feel like I work more on breastfeeding protection and breastfeeding support because we don't, in Quebec, it's very controversial sometimes to talk about breastfeeding because we are seen as putting pressure on women. Women feel this pressure and we never want this. They already have enough pressure. We want to make sure we have an environment that will help them with the family, with the policy, with the maternity protection. Again, I can talk too much about this, but it's been really, we were able to work with a regulatory body from health professions, from 13 health professions who put together a joint statement to say it's important, we need to improve our skills on breastfeeding of all health professionals. So it was very a good progress in this part. I think I'm getting to the end now. So, we have a graduate program now. Again, so this is new, but it's wonderful. It's a 30 credits on advanced interdisciplinary approach to breastfeeding. We want it's health professionals from different background who can come, and we want them to become change agents. And so I work a lot with them in terms of developing strategic capacity. So it's 30 credits. I give the 30 last credits. So the course on interprofessional collaboration, the course on practical with reflective practice, they go in other field to learn what others are doing, and a final course that we want them to become change agents. So you can hear, hopefully we want to open it to other countries, but now we just finished the first piloting of the couple of years for that, and so we are trying to evaluate the program. So some of my colleagues that I've developed, I just came at the end and I'm helping them with those courses. So I think I want to quickly get to next slide. You can go to almost the last slide in terms of my advice. And so I put, so I take every opportunity to learn from different projects. I think I cannot repeat enough. Fill in your backpack with tools. Don't be afraid to reach out to others. Really, some of the health professionals who have been in the course, I have them do a capsule. It's like just an interview with another volunteers from another health professionals, and they were always afraid sometimes to go and ask because they don't want to disturb, because they don't know what other will think, and they love it because the doors really sometimes open more easily than you think. And so people are passionate about what they're doing and they just want to talk about it. So I always encourage people to do this. Don't overlook the process. It's as important as the result, if not more. The social skills, we can call it soft skills, communications, conflict management skills, whatever, what helps you to work together. So don't see poor outcomes as failure. I mentioned that. And follow what you love. That's always one of my advice. I was fortunate to follow many passions that I had. And so I really, I feel like people, when they are passionate about what they do, they're good. And if you have different passion, that's good, because then it makes you special. Because for me, like, eu falei pouco em português. So I learned Portuguese, and so I was able to work a little bit in Brazil. And so the language was always something that I liked, but I didn't want only the language. And so it made also my life easier when I work in international nutrition in other countries. So whatever passion you have, sometimes it's challenging to make them together, but being creative also helps. So I wish you all best luck in your professional paths. I'm happy to answer any questions. I hope it trigger a few good advice and thought. Thank you.
Thank you, Isabelle, for sharing so much with us on this short time. But it was very heartfelt, like you really feel excited to share. You were a true teacher or community service person. And I'm very, very thankful for everyone. I'm sorry, I'm gonna let the teachers know that I can't see the questions on YouTube because I'm on the other. I don't know if there is any other questions, or should I ask my questions? Anna.
You can go, Anna. You can go.
Yeah? Okay. So I was going to first ask you which one was this insight that make you start to advocating for breastfeeding, but I think you already touched that. Maybe you didn't mention enough, but I think I know because I love the subject, but I think you should share with everyone else, like, why go there? You know, why stress so much about the code? What does the code brings for, you know, nutrition, like globally?
Yeah, thank you, Anna. That's a very good question. Well, I have 4 children, and my 4 breastfeeding experience has been challenging. So oftentimes it started there. So because there was no one who could help, and it was I had 2 babies with tongue ties. So the latch on was not good, and so the other was too big, so I couldn't sleep, and so and many different things, and so it make you realize that how important community breastfeeding, like, or the IBCLC are important. And so I had the chance of having people who were able to help me. But then also I realized that sometimes, well, things could have been a little bit easier if I had access to help quicker. Then I see also experience of women who really want breastfeeding, but they cannot. They didn't have access, and so it's a pain, and so for them, and it's very hard, and so it's something so special to be able to breastfeed your children. And so when you want, then you can not come back to it. And so I think for many health professionals that I see in our program as well, it starts there. They want to make sure that it doesn't happen to others, or that they get but also what I realized as a nutritionist is we are not trained enough on breastfeeding. Even if I had one professor, Micheline Baudry, who was amazing to be able to teach us many things, but it was not enough in our curriculum, which is why now I'm advocating so much, working with many health professions. And I think we have gained a momentum, which is wonderful. And what we're trying to do now is working in developing interprofessional work on breastfeeding. Because then when I start my course on interprofessional collaboration, people would tell me, I want to know what a nutritionist does on breastfeeding. I want to know what the nurse does, what the chiropractor does. But in fact, there is no a good easy response to that or answer, because the people that I have in front of me who are specialists also with breastfeeding, it's because they have developed, it's not all nurses or all nutritionists or so we need to understand better what a nutritionist can do, and then we can better see, like, okay, well, this is the part that I can work. We have like speech therapists, like an speech therapist as a student. I said, well, that's interesting, I never thought about that. And then she make us realize how much she can also bring to the table. And so women come in the perinatal continuum in different doors. So if we have the minimum training, then we can catch them and refer them to the right person. But then we need to understand, how do we communicate better together? So I feel like there is so much more that we can do, but IBCLC needs to be more recognized also. And so this is the part of the profession, but also in nutrition, well, the breast milk is the best thing ever so we need to have more training in this area. And so for the code, why it became so important is because I've seen how the companies, unfortunately, are really powerful. Professor Anna, we met together at the Codex. The Codex is something that we should get exposed as public health people. I was not exposed before too much, so it was an amazing opportunity to learn. Unfortunately, or fortunately, I was one of the public health advocates. Maybe there were 200 people in the room, I think, or maybe we were 10, 15 public health advocates, and I had to raise my hand many times saying, I'm sorry, we have like watchdog, people who understand.
You were very brave, and your speech were very, very well.
It was intimidating to have like so many people. The industry have a lot of money, they can really be there. And so this is why we need to be stronger by working in collaboration. But I feel like I want in my course, making sure that people understand what is the Codex, why it's important, what is the code. And we think we have no power, but we do. And we have seen in many countries how they are able to make progress. So that's really by working together. So I can, and I can speak a lot. The other, and I don't know if there is a differentiation in pronunciation. Sorry.
No, it's the same. Isabelle, if you and Anna, if I can speak ask something.
Go ahead.
In your extensive experience in all those countries with breastfeeding, I was wondering which were the biggest barriers or the most challenging situation that you have faced, seeing that women trying to breastfeed, because you have talked about a little bit of our knowledge, our training, but I don't know, living in that countries where you had the opportunity to give some education, some training, but what did you see that were the most challenging things in that countries? I don't know, something regarding the environment, because you had 4 children and you hold all those knowledge, but the system is not easy. The companies and what else? I would like to hear a little bit more.
Yeah, thank you. Well, many of them. You mentioned the companies, so I'll just say a few words. Sometimes I project in my classes an elephant and a mouse, and I feel like I'm the mouse working breastfeeding with no money and a lot of volunteer and good intention, but they are so powerful in terms of the funding that they had. So it was like an industry of 55 billion per year in 2019. So now it's increasing and it's continuing. So we don't have a lot of funding, which is why we need to act differently. So I think, for example, the marketing on the social media, for example, so it's reaching a lot of women, and so we need to be working on trying to make sure that there is some kind of rules, which is why now we work on the codes a lot. It's sometimes we need to be patient and have small and quick wins. And so I think that's important, but sometimes it can take many years. So, and because there is turnover, because sometimes codes are downgraded. In Laos, for example, people change and then you need to do again. And so that's the challenge. But I feel so hopeful with the program that we developed, the graduate program of health professionals, because they understand the value. And now that we are learning together and we're teaching them to become change agents, I feel like they have confidence that they can do change in their area, but sometimes their area are quite important. So I feel like you are in a good place. You have access to many students, so your part of the work is extremely important. Anna, by just Codex, I never heard about Codex in all my 20 years of universities. And so I want to make sure that people hear about it and get interested, and they see like policy, it's not just something out there, it's something that we can advocate for. So gaining advocacy. So because, so I feel like the challenges come from every single places, but by building a stronger health advocates, health professionals, then we can spread ourselves and we can really be strong in terms of so I use the language of taking a window of opportunity. So window of opportunity, it's something that open and you see that there is a chance of influencing something. And one of my students, she say, Isabelle, I saw that the government is working on this prevention strategy. Isn't it a window of opportunity, as you mentioned? I say, yes. And so then I spread, now I'm getting in contact with others and I spread the words to many. And so we all publish or send letters to making sure that breastfeeding was there, nutrition was there. And so getting organized and making sure that we not only seize the window of opportunity, but we can create them. And so how do we create them? How do we push things? And so I feel like also, so I'm working more, I'm talking more about the strategy than the challenges, because I feel that the challenges are all over, being at the clinical level. So neonatology, my little brother had a baby in neonatology, and I feel sad because they couldn't breastfeed. And one of lactation consultants, she say, you know what, I realized that my work is to repair something that should never have been broken. And I say, wow, this is like, I have goosebumps just to mention it again. I feel like it's true, like they need support right at the beginning. Why do we have a program that talk to every single mother about vaccination when breastfeeding is the first vaccine? So again, we just need to be changing our mindset in terms of what are all single opportunity to be able to talk about it. I will stop here because again, I can speak too much.
Wow, and I think you also answered another question that we had, and you gave lots of advice for us that are in the early career researchers. Especially, I think you're showing a good, amazing example of being passionate about something is going to make you go beyond just being a researcher, but wanting to be like making impact, advocating and influencing the law and the policies, or which one of the structures that you try. I want to comment something to you. Yesterday we were in the parties, I don't know, the city hall, and we had a symposium, a congress about breastfeeding, because August is coming, and the World Week, and at this conference, in the end, there was so much information. We talk about microbiota, we talk about law for protection, for maternity leaves and stuff. And it was so much, and no one had any questions. And I was like, okay, so if no one has any question, I'm gonna say something, And everyone that was there was a gynecologist, this pediatrician talking about microbiota. They were bringing lots of information, but there was nothing in the agenda of the event thinking about like what we're gonna do with this information. Now we just go home and have dinner? No, can't just go back to our lives. And I said, like, I would like to say something that no one said, because one of the pediatricians brought up the nutrition, the complementation of breastfeeding, and how he sees that as a huger problem. Like, it's not enough just support breastfeeding. We need to teach family to feed better. And he went over that a lot, and everyone was like, why is he talking about that? We want to hear about breastfeeding. And he was seeing like the next level of the problem. And in the end, I was like, okay, so we talk about everything. We talk about birth, breastfeeding, and then malnutrition for kids and families and obesity. And I want to talk about like public kitchens. And why are not we doing this? Like, we need public kitchens, we need public restaurants. popular for people, because one of the hardest things ever from being a researcher, a mom, and a working mom, is to cook every day. And it just kills me. It's exhaustive to balance protein, vegetables, and everything every single day. For I also have 3 kids. So I was like, let's go. Let's live here like with any commitment. How about we go to the city hall right here? Because we have here in the city a public kitchen that's a huge fight, because they don't want to let the people that are homeless get in. So I can't get in, the homeless can't get in. I don't know why that public restaurant exists. So, but everyone was just, leaving with the information and not doing anything about that. And also my teacher, my advisor, she was like, yeah, I also want to talk about something. She said, everyone that's here works somewhere, like maybe in a hospital, maybe in a company. And we have a law here in Brazil that's about, it's called the working mother room, which means that if you are working in a place that there is more than 30 women, you need to have a room for breastfeeding. You have a cozy room where it's going to have support for breastfeeding, it's going to have a fridge for pumping, and it's going to be supporting these working women. And it's an amazing project. It's really good. It's legal. And we just have maybe not 20 in the whole state. So she was like, how about you guys leave this task to your works, because you are convinced that breastfeeding is amazing. It's really good. And do you have that in your work? Do you have more than 30 women? Because sometimes in hospitals, you don't have a room. So you work to support other women's breastfeeding. But if you are a nurse and you're nursing, you can't pump. So I'm really happy to hear it today. And I was really, I feel really identified with everything you said, because what's the goal of producing so much knowledge if we're not gonna make something change, right? So I think this is the biggest gift you brought us today. Is really good. And I would like to make it last question, if you have 5 minutes, if they let me, which is when you're working, how do you approach the interdisciplinary collaboration on this interprofessional work? Because I have, this is the question of my master, actually. My master project, I'm asking, how is the interprofessional care for supporting breastfeeding in an ICU, in the emergency for babies, preemies, and I want to ask the professionals, because I think I have this feeling and I have this idea that is everyone's job, but it's no one's responsibility, professionally. Everyone should be advising the mom, but who is the health professional that's gonna be responsible for that? As whenever we have any diagnosis, you have cancer, you're gonna have your oncologist, right? If you have anything very particular in your health, we are always gonna have someone that's gonna advise you officially and say, hey, you need to do this treatment. This is really serious, what's going on. But in breastfeeding, no, everyone is gonna give you information, is gonna give you support, supposedly, but who is gonna make sure what's going on, take notes and do the follow-up and make the decisions? And sometimes we don't know which one of the professor or how this is going to happen. So
I'm taking the ball. I read that I have 5 minutes. Is that correct? I have 5 minutes, and I'll try to address many things. You've said many, many important things, Anna. So thank you for this, because I feel like we could talk for a few hours more. So maybe we can do another time for sure. So
you can come to Brazil to stay a little bit with us.
Eu gostaria muito. Eu gostaria, faz tanto tempo, eu adoro o Brasil. And how do we do interprofessional collaboration? Well, this is something completely new for about breastfeeding. So you are right on. So good. This is a good question. It needs to evolve. It needs to continue. We need to see how first what does a nutritionist can do for breastfeeding? So we need to work separately also in terms of what can every single profession also bring. And there is one paper published that it says like there is no captain on the ship. So it's from, I think, one student of Kati Rasmussen, who was one of my professor at Cornell. And I like it because there is no captain. It means like, as you say, it's everyone's responsibility, no one's responsibility. So, but the good thing is, you know, between different professions, sometimes there are some professional fights. So this is your part of, this is my, so breastfeeding is not like this. It's not one reserved act. I'm not sure if it's the right terminology. So it's not a reserve. So it means that everyone can step in, and it's good because moms are going to see different professionals. So if we have the minimum, the bare minimum, and now the World Health Organization and UNICEF have published the advocacy and the breastfeeding verification toolkit. So if you haven't seen now, there is another expansion now, but it's good because a few years ago we didn't have any. What are the minimum competency that all health professionals should have? Now we have this. It's a great tool. I love it. Now they are working on expanded to more at the community level. So the team of Louise Dumas and her wonderful team have developed this. So I think we are right at the edge of developing it. So continue. That's a good thing to continue. And I want to just touch quickly on what you just mentioned in terms of, I think everything that you discussed was about leadership, about change agent, about strategic capacity. Every single person here, being here as a professor, as a student, but also as professionals, we can make a difference. Sometimes we didn't get many skills in terms of leadership. We don't know how to, but I feel like many of my students who are health professionals, they just need trusts. And so I try to encourage them. They know, and after just a few course and a few diary they work on collaboration, they really develop a different approach. So I think by not giving too much, but by working on our leadership skills, our communication skills, then we can really become confident. So I had the chance. I was someone very introvert. I was not someone who was very confident, but life brought me many challenges that really, so I think everyone can develop this. There are great course. It's good. Like my student, they do conflict resolution, auto-evaluation. So when I am in a conflict, am I avoider or I'm a competitor? So those kind of work, social soft skills are very important because it helped you going over a little bit of just your normal work. I think this is what we need to do and so I encourage everyone who is kind of listening. It's just like we can do it, but it's just a matter in terms of, okay, well, am I going to expose myself? And I feel like the recipe for success, Alive and Thrive has done it so quickly. They have a 4-part process for advocacy. We need to become great advocacy people. So what is the evidence that we need? What are data that we need to be able to then develop some messages, key messages? If you talk to a medical doctor, you can talk the language of a scientific person. But if you talk to a policymaker, you're better to have your arguments about costs because they need to have budget. So you need to tailor your messages to the people that you're trying to influence. Then another process is develop consensus. So once you have your messages, how can I make sure that this person, in the big event that I was mentioning sometime, help us to have a consensus, and then also making sure that we have partnership. And so, Anna, what you mentioned is, well, it's good that you raised this point, is how do we go forward? Sometimes it's just like, can we create a small group? So this small group will continue afterwards. This is something we've done. Sometimes we do it for many years, but sometimes we just need to have this group of key people engaged, and then we can work. So I think we'll have to wait for next time. But thank you for invitations. It was nice speaking with you.
Very good to hear you.
I'm sorry, Anne.
I'm asking you a question that you answer now. So thank you very much about advocacy. That is something that you don't have training for. So I'm very impressed. Thank you very much, Isabelle.
Yeah, well, you're welcome. I will
Thank you,
share
Isabelle.
documents with the two Hannah. So share documents. So
Yeah.
I try to have the link, but it's public health advocacy from Alive and Thrive and UNICEF, and so it's really a simple guide that really help you to do a stakeholder analysis. It's great. It's wonderful. Thank you.
Thank you so much,
Thank you,
Isabelle.
Isabelle. Thank you, Isabelle. Thank you, Anna. It was really inspiring. Congratulations, and thank you very much for sharing it with us.
You're welcome.
Now we will have with us Dr. Thais Favero Alves, who will share her expertise on dissemination and implementation science. So I'd like to ask Catiel to introduce our next guest.
Hello, everyone. Can you hear me?
Yes.
Yes. Hello, Thais. Hello, Professors Danielle, Débora, and Ana Carolina. Well, my name is Catiele, and I am a PhD student in nursing here at the Federal University of Santa Catarina. It's a pleasure to be here today to introduce our guest, Professor Thais Favero Alves. So, Professor Thais is a nurse and currently works as an assistant professor at the College of Public Health in Department of Health Services Research Administration at the University of Nebraska in the United States. She has a PhD in nursing from the Federal University of Santa Catarina, with part of her studies completed at University of Nebraska Medical Center. She graduated in nursing from UFSC, and he has a master's degree in health and work administration. She was a visiting professor here in UFSC, and she also worked as a postdoctoral research associate at the University of Nebraska in the Department of Health Promotion and Department of Health Services Research Administration. So thank you again, Professor Thais. Thank you so much for accepting our invitation, and we really happy for hear you.
Thank you. Hello, everyone. It's a pleasure being here. I was really excited about the invite, Catiele. Thank you so much. As a UFSC baby, it's always a pleasure to come back and share some ideas. I don't know if I can share my presentation or if I have to send someone.
It's not possible hear you, Laura.
Can you hear me now?
Yes.
Okay, so you can share your presentation. We have an icon here below your screen that says share, and it has a little screen with a plus.
Yeah, I just want to make sure that I'm only sharing the slide.
Yes, you can share the screen, or you can upload your presentation here.
Okay,
whatever you prefer.
Yeah, I'm just going to upload the presentation. Just give me a second. It's uploading. It says processing. I hope it did it correctly.
I think it's okay. It takes a minute.
Okay. Good. So Can you see my presentation now? Perfect.
Yes.
So I was asked to speak a little bit about my experience with dissemination implementation science and how I've been using that in my work, my research. So I am now, since 2022, since I moved to the US for my first postdoc, I've been working with digital health interventions. That's what I've been doing, with a focus on developing culturally relevant digital health interventions. And all my research is based on DNI, dissemination implementation science. So this is what I'm going to share a little bit about, so how I'm doing that cultural relevant DHI using dissemination implementation science. So I'm just going to divide this presentation in 3 main topics: a brief overview about DNI. So every time I say DNI, I'm talking about dissemination implementation. My experience, what I'm doing right now, and applications. So I'm just going to share examples from 3 research projects that I worked and am working right now. I'm not going to go into deep details because we don't have the time, but I just want to, like, okay, this is how we can do this, like just give some highlights on how we can apply this knowledge. So I suggest anyone that's interested in knowing more about DNI, I suggest these 3 resources. This is an amazing book, and these 2 websites also pretty good. So most of the concepts that I'm going to share today, you can find in this book. I use it a lot, so it's kind of our Bible per se. So I truly, I think we should maybe check that out. So what is DNI? Some people think they've never heard about it, but probably yes, because it's called different names before. In Portuguese, translação do conhecimento, or ciência da disseminação e implementação. So we can talk about translational research, population health, intervention research, scaling up. That's also DNI. And always start with the basic question when we think about this. So what we know is the same that what we practice. And I mean, what we know as academia, as researchers, as scientists, is that the same that we practice when are in clinical settings, primary care, any setting? Is that the same? So everything that we know, evidence-based, that should be done, are we doing that? And probably you know the answer already, but no, we are not. There's a thing called research waste. As little as 14% of published evidence is translated into practice. So everything that we publish, evidence-based information, only 14% is actually translated to practice. And what it is, when it is, it takes an average of 17 years to be translated. So we waste a lot of research and good evidence-based knowledge that could be making life better for a lot of people. It could be making our work easier as healthcare professionals. Could be saving money from systems. And we are not doing that, and for many reasons. So this is why we have DNI. This is why we have a brain that when we're planning a research, a new intervention, we have this in mind. So DNI comes to kind of fill this one. So there's a gap between the care that could be delivered and the care that is actually practiced. And DNI addresses this gap. So what we know, what we practice, how can we bridge this gap? How can we build something in the middle? How can we do research that actually addresses this gap? So it's a full process from planning to implementing. This is DNI. Just basic concepts. So when you're talking about dissemination, we're going to study process factors that can guarantee that our intervention or program or project, I'm going to work with technology here, but it could be anything. It could be a protocol, anything. So how people actually use what we did, what we developed. So dissemination is studying how our intervention is actually getting to the target population, is reaching who we want it to reach, and it's being used. So it's being useful. And implementation, we study how we can integrate that intervention, that program, that project in a particular setting. So if I'm developing a new protocol for my clinical setting, how can I guarantee that the health professionals are actually going to use that protocol and adopt, and that it's going to be part of the routine, like organically, and not a burden that would actually be helpful. So we have three main factors associated with the speed and the extent of D&I, and they talk to each other all the time. It's impossible to think a research with only one of them without considering the others, because if you don't, then you're probably going to fall in that 14% or 17 years is taking longer because they all communicate. So most of my presentation from now on, and when I'm sharing the research that I've been working, I'm going to have these three factors. So characteristics of the intervention itself, which mean my technology or the project, the protocol, whatever, and the adopters. So we could be individual organization. I could be developing something. I could develop something for a patient, a caregiver, a manager, a health professional. So it depends. And the contextual factor, context, where is this happening? So we basically have to ask ourselves when we are planning our intervention development, when we are evaluating, is the intervention better than other options that people have already? Is compatible with the target population that I'm trying to reach? Is that acceptable? Is that appropriate? Is that feasible? Is that expensive? That's also very important. Sometimes we want to do some research because I really like this topic, but that's not why we do research. We do research for a reason. We have a problem to solve. We need to help people, especially our field of research. So if there's another option out there that could just be improved and reach more people, I don't need to develop a full new one that's going to be more expensive. And if I could just fix a little thing in what they already have and make this good for them. So this is how we think about the intervention itself. And then the adopters, their attitudes, their behaviors, their education level, individual concerns, motivations to adopt what we are developing, and the contextual factors, social support, norms, culture, processes, infrastructure, all of that matters a lot when we are talking about implementing and disseminating an intervention. So my work right now, what I'm doing, my work focuses on improving patient-centric care. So I develop and I evaluate, not by myself, obviously I'm a part of a big team, digital health interventions. And I do use implementation science to aggregate those processes, cultural relevance, health literacy, technology literacy, because I am talking about DHI, health communication strategies, and healthcare access. We need to increase healthcare access. Remember, I'm in a different context of healthcare system here now. So for me, from my perspective, we don't have universal healthcare here. So for me, I always have the goal of increasing access to healthcare. I want healthcare, I want good health information to reach more people. So that's one of my goals when I do what I do. And as you can see, those words that I kind of highlighted, you can see intervention, features there, adopters, and contextual factors, because we're talking about the intervention itself, the adopters, and the cultural context. So it's all related in my field of work. So as I mentioned at the beginning, I use D&I to develop culturally relevant digital health interventions. What does that mean? So digital health intervention, this is the World Health Organization think this is how they define it. It's mobile and digital technologies that are used to support individuals and system needs. And then those technologies could be for patient, caregiver, healthcare provider, managers, data services. And then we have culture, that is the set of distinct spiritual, material, intellectual, emotional features of a society or a social group. And when we have all of that together, we have the culturally relevant digital health intervention. And what I want to highlight here is I have digital health intervention in that concept. So I'm talking about the intervention itself. When I'm talking for who, target population, clients, healthcare providers, caregiver services, I'm talking about doctors. And when I'm talking about culture, I'm talking about context. So again, it's all related in the same field of research. We have D&I right there already. It's impossible to think about developing this without taking D&I into consideration. How do we apply, basically? These are the main steps that we use when we are starting to think about any new research project. First of all, know your population, their characteristics and their needs. What do we know already? What do we know about this population? What do we know about our target population? If we know a lot, awesome, but do we need other important information and how we can get this information? So this, of course, specific data collection strategies. It could be surveys, it could be interviews, it could be focus groups, reviews. What do we know? What do we need to know to develop that good intervention, that good protocol, that good project to reach these people? Second, develop for them, but with them as well. We want target population to get access to what we are developing, right? We want to bridge that gap. We have that gap. So what I know, it's important, I know to develop it, but I want people to use it. I want it to get to the target population, their final destination. So it's important to do with them and for them because they're going to use it. So they should be part of the process. We usually do participatory research and user-centric designs for developing our interventions. And then all the time, constant evaluation and improvement, testing all the time and improving. We test and we improve because, again, we want this to be sustainable, this whole process. So for each of the steps, we have specific data collection strategies, but the whole research, the full research, that is based on dissemination implementation science models or frameworks. So I'm going to collect data in different ways. It could be quantitative, qualitative. But when I'm integrating that data in developing my intervention, I have a model or D&I framework, mostly basing my research, because again, I want this to be scaled up, sustainable. So I'm going to share an example from 3 projects. I'll try to be super brief. I don't want to bore you too much. But yeah, so we have here 3 main projects that I've worked and been working since I moved to the US, since I joined UNMC. Okay, so I think this is important to say. I forgot to say that before Caccielli. I started working with D&I during my PhD, when I was doing my PhD at UFSC, at the nursing program. There were like 2 visiting professors from UNMC at UFSC, and they had a special topic course that was systematic review using the REAIM framework. And REAIM framework is a D&I framework. I took that class and I was like, okay, this is what I needed. I didn't know that I needed this for my dissertation, but that's exactly what I needed. So then I applied for the fellowship. That's when I got a doutorado sanduíche. I don't know how to translate that to English, but you know what I mean. That I got a year of doutorado sanduíche here at UNMC. I was working with them, but Dr. Fabiana Brito and Fabio Almeida, I think they're at UFSC again now. Not sure, but I think they are. And I was here for a year just learning and implementing REAIM framework. So I could work in different projects that they were using dissemination implementation science. So when I came back to Brazil to finalize my data collection and my dissertation, I appropriated the REAIM and translated to my field of research. That was technology already. So I was not doing technology here for that year specifically, with the same technology that I was working in my dissertation, but I was able to, okay, this is how the science behind it works. We can apply it to any type of study. So that's what I did. But anyways, that was my PhD when I was at UFSC. So when I moved here first time, I worked as a postdoc with Dr. Fabiana Brito, one of these professors, in a project called Cultural Adaptation and Feasibility Testing of a Technology-Based Pediatric Weight Management Intervention for Rural Hispanic Latino Communities, so rural Nebraska. I live in Nebraska. In Nebraska, as you probably heard, is a rural state. So, and we have a big Latino population here, especially in rural areas. So the second project, I worked as a postdoc from 24 until May this year, probably, before I moved to assistant professor position. And that is my MDC journey. That's an mHealth app, usability and satisfaction assessment. We are still working on that project. The project one, it's over already. We're publishing the papers. We had 2 already published. We are working on other papers, finalizing some data analysis, but that project is over. Project 2 it's ongoing. I'm just not a postdoc anymore, but we're still working on that research. And project 3 is my first project here as a PI that I just got the funding early this year. So it's evaluation of usability and cultural relevance of an health app for Hispanic Latinos with rheumatoid arthritis, also a big population here. So the first project, this was an intervention. They had a workbook. Families received a workbook and IVR calls. So those automatic calls, remind you to do this. You can set up goals. About food, about exercising. What I'm struggling with. It was related to childhood obesity, but it was for families, for the parents. So the parents were like developing the program. And it was based on a project that happened before, but in another state with a different population. So it was mostly for white families in the US, American white families living in a different state. So completely different context. And it was helpful for them. But again, we cannot just translate that to Spanish and apply in rural Nebraska because the context, the adopters are different. So there was a full cultural adaptation process to develop that one, and then did a trial to see if that was effective, feasible or not. So I'm just going to share this. I don't know. I hope you can see a little bit. So this was the approach only for AIM-1 before the feasibility trial, just for the cultural adaptation. It had a full framework behind it based on dissemination implementation science and multiple steps to develop it, just this aim. So we had the focus groups, cultural relevance questionnaire. Then there was adaptation of that translation process, then feedback again, testing. And then when they're like, okay, finally, it's good enough, this version is good enough, then we go to the feasibility trial and they actually apply, they do the program, they engage in the program for 6 months. But this was just to actually finalize the materials, because again, it's not just translating something there is already. Every context is different and the adopters is different. So it's a challenge to maintain the same evidence-based content that you need, because you know that will be helpful. There's science behind it, but in a way, transmit that in a way that makes sense for the target population that you're trying to reach. This is just a summary of the key methodological strategies that we use for AIM-1. Like I told you, I'm just going to cite it, so it kind of makes sense how we can do the data collections. So for this project, AIM-1, we had interviews, we had focus groups. We applied the cultural relevance questionnaire. We had the organizational readiness to change assessment. That was with health professionals, community health workers, managers. So again, everything that will be involved should have a say in the project. We had the after scenario questionnaire and the system usability scale for the usability tests. So we did like brief tests with the calls, with the workbook, and see what we needed to change, what we needed to adjust in the materials before scaling up. We had the whole health literacy advisor. We got a software for that. So make sure that our levels, the way our material is written, is going to reach the most people that we can. It should not be hard. It should be easy for anyone to follow. And then we have a specific framework to kind of combine all these results, interpret the data, and translate it into a new, better project. This is project 2. So my MBC journey, mHealth app. So my MBC journey was a mobile application that the research team that I'm working now, they developed before I joined them. So it's a mobile app for patients with metastatic breast cancer. That's why it's my MBC journey. The app was developed to improve patient-provider communication. So it's going to kind of gather some data in between their clinical encounters and help them track how they're feeling, what they're going to talk to their provider later that. And now we are doing the usability and satisfaction assessment. So again, the app was already developed, helping test and improve the technology. This was the design process that we choose for this development. So we have a design thinking process. It has 6 main steps. So the first 2 emphasize and define is when we have the content development. So for this one, we use interviews and the market scan of apps. Then we have ideate and prototype, steps 3 and 4. That's when we actually develop the app, the prototype, and then the full app. And that's design, that's app design. And then we have test, and the future will be step 6 that will be implement, that will be scaled up, but we're not there yet. We need to be sure that this is good enough to be scaled up, implement. So again, dissemination implementation size before the implementation. We want to make sure that when we implement and then disseminate, it will be good enough. So this is the background process. So we are thinking about the implementation and the dissemination, but we need this to be done. The base behind it to be good enough and, attend their needs. So otherwise it would not be a successful implementation process. And we're like, oh, we lost years doing this, money doing this, patients participated, and what's there for them now if this is not working? So this is where we are right now, the step 5 that we are testing usability and satisfaction. These are the key methodological strategies that we have so far from step 1 to 5. So we have interviews with patients and health professionals. We have the market scan of apps. So do we have any app doing this already for this population? No, we don't. Because if we do, is that good enough? Is that good? Is that working? Are people using? Why am I going to develop something that it's already there? But so that's important also when we're doing a project. So no, they didn't have any options. There's no other app doing what we are planning to do here. Then we have the mobile application ready scale that kind of addresses features of the app, the design, the language, and the user version. So we have one for healthcare professionals and one for the patients, because again, it's to improve patient-provider communication. So it should make sense for both. And the system usability scale for the usability testing and this whole design thinking process background. The third project, this is the Run RA, is an app for Latinos with arthritis. This app was not developed initially for Latinos. It was developed in English. And now we have the Hispanic version of it. So the project that I wrote, we just got the fund, will evaluate the usability of the app, if they need this, they want this, but also if the information is making sense. It's not just in Spanish, it's actually making sense for them. If they want to use it, that's another thing. So aim 1, we're going to assess health literacy, e-health literacy, technology trust, digital self-efficacy levels of these patients, these Hispanic Latinos with RA. And again, not everyone wants to use technology, wants to put that information on an app, especially these days. Things are happening. Not everyone will feel comfortable using technology, but most people do. And when we don't have healthcare getting to people anywhere, because we don't have that logic of universal healthcare system, we need to find ways to still reach these people. Not expensive, in a non-expensive way, and make sure that they are receiving evidence-based, reliable information. And if they, anyways, that they can reach the health professionals if they want to, if they need to, but that they have like base access to any information that seems like a privilege for some people, unfortunately. Yeah. So aim 2 will determine the cultural relevance, usability, and patient satisfaction. So no providers for this portion. Aim 2 is just for the patient satisfaction, because this app is for patients, it's not for the providers. But we will talk to healthcare providers for aim 3 to understand their perspectives on the challenges, the potentials of the Run-A app for improving communication later on. So we have like this 3 aims for this project. This is just how we are organizing our methodology. So we can see here we have the data collection with the Hispanic Latinos, with RA, and then we have the data collection with the healthcare providers. So we have all these scales, the health literacy, technology literacy. So again, know your target population, but what do you need to know more? We don't know this. I don't know their health literacy level. And if I don't know their health literacy level, I don't know how to phrase the information in Spanish. I need to know how to write this in a way that will be accessible to it for everyone. Their technology literacy level. So how hard is that actually to use, to assess that mobile app, to download it, to use it daily? Do I trust this? Do I trust this technology? Do I want to do this? And then we're going to assess the app itself, like I said, just repeating myself here. And then aim 3 with the healthcare providers. Every step of the way has its own data collection instrument, strategy, and we will analyze this data independently. So the qualitative portion will be done qualitative, the service this, the usability it's another methodology. We're going to analyze all that. And then when we have these results, we're going to merge that data and interpret, because this is a mixed method study, using FRAME, which is also a D&I science framework. So again, we're doing our thing, we're doing research, but we are thinking with a D&I brain, so we make sure that we are addressing all the gaps that we need. And then we're going to improve the app and make sure that, okay, now I can implement it. Now it's good enough. People can start using that. And these are the key methodological strategies that we are using for this project. Interviews again, this very specific health literacy assessment for Hispanic Latinos. The technology literacy scale, the trust scale, digital self-efficacy. I just look at the time. I'm so sorry. I'm over. I have one more slide, I think. So just look at the time. Then cultural relevance questionnaire again, the system usability scale, and the framework. That's a D&I framework to analyze the data. So I want to finish by saying that, of course, this is my field of research, culturally relevant digital health interventions, but culture matters when we are talking about any project, because again, we want to reach someone. We want it to get to our target population. And if I'm not talking about the individuals, but I'm talking about organizational, you can talk about organizational culture. That's going to make a lot of difference if that protocol, the new process, will be actually implemented in a work setting as well. So culture matters anytime. And D&I matters as well. Because if we are not addressing our research, our questions, the development with that brain of trying to bridge this gap, how can I make this actually useful? I have this beautiful idea. I have this beautiful project that I'm going to do that for years. I know this is important. How can I start from the beginning, from year one of my PhD, thinking, okay, what can I do to make sure that people are actually going to access this information that I'm developing in the future, years from now? So it does matter. D&I does matter for any topic, not only for technology. I'm talking about technology because that is my field, but for anything. We can meet patients' needs. Again, if we're not talking about patients, we can meet target population's needs. We can improve quality of care or work. We can improve our work. We can increase access to healthcare, and that's why I'm doing what I'm doing now. And I think super important, develop sustainable interventions, because we want it to be sustainable. We want it to be there for a long time and people to use it, and we can improve it because we are learning with them as they are using, but we want this to be sustainable. That the time, the brain, the mental health, the money that we are investing now in this research will pay off in the future, will help people, and will be sustainable. We have, when we use D&I to develop this, there's a better chance that the reach will be better. So this will reach more people. It will be largely adopted because it's good. If I'm reaching more people and it's good, it's going to be adopted. Otherwise, no. It's more effective because it's good, it's reaching more people, and it's being adopted. And it's cost efficient because I'm not just losing money on something that's not feasible. That's it. Thank you all. This is my email in case you have any question or just want to talk about this. I'll be happy to share more.
Thank you, Professor Thais. It's really interesting hear you, because this subject is really important when we research anything that you tell with us. We have some questions for you about your research and career, because you develop a part of your research here in Brazil.
Mm-hmm.
And what do you think about the difference between to do something for implementation and dissemination sites here in Brazil and here that you live now and works? Is different what way we can do here in Brazil?
Yeah, there's a few differences, but I'm gonna just address, I think, the main one, in my opinion. The scheme, like the way we fund research. Sometimes in Brazil, we don't fund research thinking long-term research. And that is a problem. We see that a lot. When you're doing your master's, your PhD, you do some beautiful research. When you leave the program, who's doing that now? Who is continuing the research that you're doing? I think that's one of the things that are kind of stopping us from doing research with more D&I background, that framework, that idea, that planning behind it, because in years from now, okay, this is actually happening. So I think the way that we fund our research I don't know. I know that not everyone who's doing a PhD or a master's will stay in academia, but maybe we figure like strengthen like the research groups or have other partnerships, because I feel like sometimes we lost a beautiful research, and sometimes a research can take years, not only 4 years of PhD, but like years. So we need someone to continue with that, and I think we kind of lost in that process. And maybe here in the US, the funding is a little bit different. When you're submitting a grant, you need to prove that your team, your partners, you work well enough together, and the university has a structure that, okay, if you're fired or if you move to someone else is continuing that research, and that you have a plan for a long term. If you don't prove that in your grant application, you're not getting the money for that project. So you have kind of more time to develop it. That's what I'll say. But there's, of course, other questions, but I think maybe that's one that I can see.
In the same way, I write about what do you think about the potentials and difficulties of implementation science in the health area or health research.
Yeah, so I think that is a main one. There's so many. Oof. I can speak from like a scientific background, like when we're thinking about planning a research project, but also all these elements talking to each other, the adopters, the intervention, and the context. We need social support, we need laws, we need money, we need time, so that's all working together. It's impossible to do a beautiful D&I research with only, I have this beautiful brain right here, I'm gonna fix it. No, you need a structure, you need a place, an environment to actually do your work, you need resources to access your target population. So it's a combine. So it depends. Some settings could be easier than others. In a place where, for example, primary care is more organized, it would be easier to develop a research in primary care, because the setting is better, you have more access to healthcare professionals, you have more information, you have more data, so you can identify the needs more easily, you can reach the people more easily. In the hospital setting, the same thing, the clinical setting. When it's a place that's more organized, it's easier to reach. But at the same time, we need research in places that we need to organize from scratch. So I think that's a big challenge, that we know that it's not only our idea, our brains, there's a full support system that we need. And sometimes we don't get it. But the potential, I think it's immense. Because again, we have amazing ideas. We know, we have a pretty good clue of like what we need, what people need, and how we can change it. So if we can, maybe from the beginning of writing a project, we could stop and think about this a little bit. Okay, I have this idea, this is my object, this is my work. I'm gonna take 2 steps back and think, in 5 years from now, what can I do now in my planning that will make easier for this research to reach my target population? So I think the potential is, if we start thinking about this from day one of our master's, day one of a PhD, think about when I'm planning, when I'm developing my methods, I can think about the after. Not only after I finish my PhD, I get my diploma, I go home, the research ends. No, this could actually reach people in the future. After this 4 years, how can I do this? How can I write a method, a project that can actually be better? And if I'm not able to do it, someone from my research group can. This is beautiful. We don't need to lose this research, the time and the money. We can continue with this project and go ahead with it.
Yes. And what advice would you give to someone who is starting their academic career now and aspires to an international career?
Be brave. No, that's for national international career. That's always for researchers. Always be brave. No, I think be curious and be proactive. There's a lot going on. We need to be, I don't want to use this word, but I will, annoying sometimes. You know, when you're curious enough to be annoying, and keep asking people and help, but hey, what are you doing? Look for information, be proactive. I was a really annoying PhD student. That's why I got the doutorado sanduíche and the postdoc here and the professor position now, because I'm always curious and I want to know. And how can I help? What can I do? Talk to people, be curious about things, be proactive. There's a lot of opportunities right there, but we need to find those. That takes time and a little bit of courage. And yeah, annoying people a little bit, but in a polite way. But yeah, you gotta be out there. You gotta be brave and you gotta be curious and be proactive. Don't think about it. Oh, I wish. Who's doing that? I'm gonna talk to this person. If this person doesn't know or doesn't have an opportunity for me, she can recommend me someone. He can recommend me someone. And this is how we keep doing and building beautiful network, international research. Yeah, that's my experience. Probably there's other ways. This was my way. Asking a lot. Yeah.
Wow, thank you. There are another questions? Professor Elena or not? So, thank you, Professor Thais. Thank you very much. I guess that we had a productive afternoon. I hope that you also enjoy having this experience. Your words will surely inspire and encourage our audience. So, thank you.
Thank you very much, Thais. It's so nice to see an UFSCiana going so far. It's really inspiring. Congratulations for your work. And thank you very much for accepting our invitation. Thank you very much. And for our audience, I just would like to remember that in the next Thursday, you have the last one seminar with Dr. Melissa Fernandez. It's not my cousin, but she's coming from the University of Ottawa to talk a little bit about her journey in digital food environment. Okay, it will be at 2 p.m. at the same YouTube channel, so you are all invited. Thank you very much. Bye-bye.